Welcome to our 6th webinar in our 9-part series of the End of Life Symposium. Today's focus is on how medical aid in dying really works in authorized states. Without further ado, I'd like to introduce to you a very inspiring and talented physician. She serves as the chair and course director for the End of Life Symposium, Dr. Chandana Banerjee.
Hello, and welcome to the End of Life webinar series. As many of you know, this year's webinar is divided into 3 domains: humanities at the end of life, clinical aspects at the end of life, and medical aid in dying. I'd like to introduce you to Matt Whitaker, who will be the main moderator for today's session. Matt Whitaker, in his role as National Director of Integrated Programs at Compassion and Choices, works to support medical education, end-of-life planning, and client services nationwide. Over the course of his 6 years at Compassion and Choices, he has taken on various roles, including time as the State Director for California and Oregon, as they launched campaigns to increase access to end-of-life choice. Matt holds a master's in theological studies with emphasis in integrative theology, a specialty certificate in hospice and palliative care chaplaincy, and he is a board-certified music therapist. Without further delay, I will let Matt Whitaker introduce the speakers.
Wonderful, wonderful. Thank you so much, Dr. Banerjee. And I am just truly honored to be able to be a part of today's webinar series and to get to be here with all of you, and especially to be with our really esteemed speakers who are on the call. I want to take a moment to introduce those folks, but first want to take a moment just to acknowledge the fact that we are speaking about the subject of medical aid in dying, and that along with each of the things that we talk about that are practical, each of the practical concerns, each of the ways that this is played out in states, there is also a personal piece to this. And that is that there are individual stories and families who have gone through this process. And so I want to make sure that we invite them into our consciousness as we speak about this topic. So I'm going to take just a moment to pause and to light a candle here at my desk. And if you are so inclined to do the same, just to acknowledge the fact that we are holding those people in our hearts and our minds as we engage in this topic. So I'm just going to do that right now. So let this just be a reminder to us that, again, everything that we talk about today in this series around end of life is because of the people that we care for and that we work with, the people who are our patients, our clients, our family members, our friends. So may we do well to remember them in all that we do, but especially today. It's now my honor to introduce our speakers for today's webinar. Again, I'll be back at the end for questions and answers, so make sure that you add those pieces to the Q&A box and we'll get to as many as possible. But first, I want to introduce you to Dr. Ryan Spielvogel, who is a family physician at Sutter Health in California. And Dr. Spielvogel goes above and beyond for his patients and for the system that he works for in being the person who has really piloted and created Sutter Health's really innovative program to ensure that patients seeking medical aid in dying are able to access it in an equitable manner. He's not only done that, but he's also made a point to engage the next generation of physicians by creating opportunities for residents to study California's medical aid in dying law and learn how to support patients in it. So we are so fortunate to have Dr. Spielvogel today on the webinar to share about his experience there at Sutter Health and again in creating the next generation of physician leaders in medicine. We're also fortunate to have on the call Samantha Trad, who is Compassion and Choices California and Hawaii State Director. And Samantha has incredibly extensive experience implementing medical aid in dying laws across the country, working to make sure that they're accessible, making sure that they are protected, and making sure that we are improving access to them, not only through structural change, but through even changing laws to make sure that they're more equitable and accessible. In fact, right now she's working in Hawaii to make sure that their law becomes one that is more accessible to more people. Samantha brings to her role extensive experience in public policy and community organizing and education. And we are all very lucky to have her open our webinar today and to tell us a little bit more about how these aid in dying laws practically play out in the states where they're authorized. So without further ado, I will turn it over to Samantha, and I will see you all at the end.
Thank you so much, Matt. And thank you all so much for being here today. Next slide, please. I want to do a quick poll and see where our audience is. So what is medical aid in dying? How familiar are you with this option? You should be seeing a poll. Are you very familiar, somewhat familiar, or not at all familiar? While you vote, I just want to say again, it's so important for people to be here today because a lot of people think that once their state authorizes medical aid in dying, that it's very easy to access, that they can just ask their doctor when their suffering becomes unbearable and pick up a prescription later on. And that is not how it works. And here at Compassion and Choices, we have over 20 years experience of medical aid in dying laws, and we've learned a lot over the last 20 years, which I'm excited to share with you today. So let's wrap up that poll. Can you show the results, please? All right, it looks like we have a pretty good mix and the majority of people are somewhat familiar. So I think you've come to the right place. All right, next slide. So it all started in Oregon over 20 years ago. Oregon was the first state in the country to authorize medical aid in dying. And since then, most of the aid in dying laws across the country have been modeled after Oregon's. There are now 9 states and Washington, D.C. have all authorized the compassionate option of medical aid in dying. You can see the light blue states are the states that have medical aid in dying laws, and the dark blue states are states that had legislation in 2020 to authorize medical aid in dying. And now currently in 2021, we have a lot more states coming on board with legislation currently moving. So where you see the yellow squares, that's where we have Compassion and Choices volunteers. So if you're interested in volunteering with us, we would love to have you. Please go to our website and you can volunteer with us. So what do I mean when I say medical aid in dying? Medical aid in dying is a medical practice that provides an eligible, terminally ill, mentally capable adult with a prognosis of 6 months or less to live, with the option for medication they can decide to self-ingest to peacefully end their lives. This is not euthanasia. This is something that a person who is already dying and they don't want to suffer at the end of their life, or they want a little bit of control over something they don't have any control over. Those are the people who choose the option of medical aid in dying to peacefully end their lives. All of the states have the same fundamental eligibility requirements. In order to access the law, you need to be an adult. Again, you need to have a terminal illness and a prognosis of 6 months or less to live. You need to be mentally capable of making your own healthcare decisions. This is a really important eligibility requirement to understand. A person who wants the option of medical aid in dying has to advocate for it themselves. This is not an option for somebody who has advanced dementia. And in fact, if you go on our website, there are a lot of other very compassionate end-of-life options for people with advanced dementia, such as Alzheimer's. The patient has to be acting voluntarily. There's a lot of safeguards to make sure that they're acting voluntarily, and they need to be able to self-ingest the medication themselves. So if a patient meets all of these eligibility requirements, then they can get a prescription in an authorized state. However, it's still not that easy. The next slide will show you the common regulatory requirements that a patient has to go through in order to get the prescription. So you can see here under the word attending, the way the law is written, it's usually described as the attending provider and the consulting provider. These tend to be physicians who are qualified to assess the patient for their terminal illness and prognosis of 6 months or less to live. In all of the authorized states right now, a patient has to have 2 different doctors confirm their eligibility. The main doctor who ends up writing the prescription is called the attending provider. And again, don't let the language confuse you. It just means that they're able to, it's any doctor who's able to assess the patient for the eligibility requirements. So the main attending provider evaluates the patient. They have 2 different consultations with the patient that's separated by a mandatory minimum waiting period. In most of the states, it's 15 days, with the exception of Hawaii, where they have a 20-day waiting period. And we're going to talk about that a little bit later on. The patient also has to fill out 2 different written requests for aid in dying, one that is signed by 2 different qualified witnesses to make sure there's no coercion, and another one generally before they take the medication. The consulting provider is the second provider who assesses the patient. Now, right now in Washington and Hawaii, there are bills to amend their laws to allow advanced practice registered nurses who are qualified with prescriptive authority, and in Washington, as well as physician assistants, the ability to also act in this way to support their patients. Most states have an optional 3rd mental capacity assessment that can be done by a psychologist, a psychiatrist, in some states, a social worker. In Hawaii, it is mandated. So a patient has to see 3 different providers in order to qualify for medical aid in dying. So that sounds like a lot. And those are the cliff notes to what a patient has to go through in order to access the law, and the responsibility that a provider has in order to support their patient. And I encourage you to go to our website or to your state department, health department's website, if you're in an authorized state, to find out exactly what you need to do to be able to support your patients in the option. But what we do know from the Department of Health across the country is that somewhere around nearly 7,000 prescriptions have been written for qualified patients. So it is possible to get through that whole process. And over 4,000 prescriptions have been ingested. Now, this statistic might seem a little strange, but we see this in all of the authorized states. About 1/3 of the patients who go through that whole process to get their medication, about 1/3 of them never actually take their medication, but just having it gives them a huge sense of relief. You can see on the next slide, this is a man named Steve Johnson. He was one of the first patients in Hawaii who accessed the law. And he and his wife said it was like a Christmas present. In fact, when Steve Johnson got his medication, his symptoms improved. He felt better. He was still terminally ill. He was still dying, but he didn't have to worry about the course that his terminal illness was going to take him on, because he knew he had this option of medical aid in dying. I talked to another man who told me he never felt more alive than the moment he got his medication, and that he hoped he never had to use it. But again, he didn't have to worry about the course that his terminal illness was going to take him on. And I think it's so important for us all to remember that people who choose medical aid in dying do not want to die, but their terminal illness has robbed them of their life. What medical aid in dying does is it gives them a little bit of control over something they don't have any control over. So who uses medical aid in dying? What we know from the data, again, from state departments of health, is that the majority of people who use the law tend to be over 65. There's about an equal percentage of men and women who use the law. We don't know about non-binary people yet, but soon, hopefully. We also know that the majority of people who choose the law tend to be dying of cancer, although there's been a rise of people with neurodegenerative diseases who choose the option of medical aid in dying. Again, as long as the person can self-ingest the medication, then this can be an option for them. And self-ingestion means that, you know, somebody else can mix the medication, they can hold the cup up for the patient, but the patient themselves has to be the one they can suck through a straw. They have to be the ones who's taking the medication into their body. And that's why we do see patients such as ALS patients who do choose the option of medical aid in dying. So that's a little overview of who uses the law and how the law works. And if you go to the next slide, You may remember back in September, the City of Hope had a really moving webinar with photographer Amanda Villegas, where she showed pictures of her husband, Chris Davis, in his final weeks. Chris desperately wanted the option of medical aid in dying. He was 29 years old, and he had a rare form of bladder disease that his grandma had actually died from. And he saw how his grandmother died, and he did not want to die the same way his grandma did. Unfortunately, Chris was unable to access medical aid in dying, even though he lived in California in an authorized state. And we're going to talk a little bit about why there are people like Chris who meet all the eligibility requirements we talked about, yet they still face insurmountable barriers to accessing the law. So barriers and roadblocks. Gary Johnson was a man who lived in East Hawaii. This article actually is from November of last year, just a few months ago. Gary's doctor said that he would support him in the option of medical aid in dying. Gary met all the requirements. Gary went through the whole process. And when he went to his second consultation after he had waited that 20 days to hopefully pick up his prescription or what he thought was going to happen, his doctor had changed his mind. And the doctor said, I can't support you in this any longer. It would be okay if you could just go home and drink a bottle of Benadryl. Gary was devastated, and it's horrifying that his doctor gave him that advice when this is an authorized option in Hawaii. Gary was so upset. He had already spent so much time trying to go through the process. Thankfully, he was able to find a doctor on the other side of the island who was able to support him. And in the end, Gary was able to access the law. But nobody should have to go through that stress and pain in their final weeks. So why couldn't Gary access it? Why did his doctor change his mind? Well, first of all, it's important to know that healthcare systems can prohibit physicians from practicing medical aid in dying. In fact, we know in California that 97% of religious healthcare systems do not let their doctors support patients in the option of medical aid in dying. In fact, there's not a single Catholic hospital healthcare system that allows their doctors to support patients in this option. So when you talk about Dignity Health, for example, Dignity is a huge healthcare system that's Catholic. It is impossible for a doctor to support a patient in the option there. And most Adventist healthcare systems don't let their doctors practice either. Now, any doctor has the right to opt out if they don't want to. If a doctor doesn't feel comfortable supporting their patient in the option, even if they're at a healthcare system that does allow doctors to practice, they don't have to support their patient in the option. However, if there's a doctor who does want to support their patient and they happen to be at a religious healthcare system or a different healthcare system that simply doesn't let their doctor support patients in the option, then they are unable to support their patient in this compassionate end of life option. And that's what we think happened to Gary. We think that his doctor didn't realize that the health system he was at didn't let doctors practice medical aid in dying. And so in the end, he wasn't able to support his patient. Finding two physicians can also be challenging for patients. You know, most doctors are not trained in end of life. And for a lot of doctors, they still have this false notion that death is somehow failure. Death, of course, is not failure. In fact, I would say that having an end of life experience that a patient doesn't want, or having a patient's wishes not be met at end of life, that is the real failure. But it's still hard for doctors to wrap their heads around end of life and medical aid in dying. And so, you know, if you know a doctor or you are a doctor who's struggling with this, I'm glad that you're here today to learn more about it. But for a lot of patients, they're not able to get through the process because they can't find those two different physicians to support them. Another big barrier is the mandatory minimum waiting period. We know from statistics that we have from Kaiser Southern California, Kaiser Hawaii, and a few other healthcare systems that a large percentage of patients who are eligible for the law don't survive the mandatory minimum waiting period. This is a picture of Dr. Omega Silva. She was an incredible champion for medical aid in dying where she lived, and she was terminally ill. And it was very difficult for her to survive the minimum waiting period. Every day she would call and ask, how much longer do I have until I can get my medication? Thankfully, she was able to survive the mandatory minimum waiting period and was able to have the end of life experience that she wanted. But it's so sad that she had to spend those last 15 days in pain just trying to make it through so that she could have this option. In fact, Kaiser Southern California, their data shows that 30% of their patients don't survive the mandatory minimum waiting period. Kaiser Hawaii last year had 34% of their patients who were eligible who did not survive the mandatory minimum waiting period. And Kaiser's great. I don't mean to make it sound like Kaiser's not. Kaisers tend to have the best internal policies and procedures, which we'll talk about in a little bit, to make sure patients don't fall through the cracks and can get through that whole process. So if Kaiser's numbers are this big, there's a problem. And part of it is patients wait too long to start the process because they don't realize how long and complicated it is to get through it. But someone who can talk about this better than me is Dr. Ryan Spielvogel. And I'm very excited to have him with us today. And so I'm going to turn it over to Dr. Spielvogel to talk about his experience supporting patients with medical aid in dying.
Thank you very much, Sam. Let's see, do I have control? Oh, I do. Okay, so I'm first just going to talk a little bit about the logistics and kind of a quick caveat here. So this is the process that we have developed. I'd love to say that this is the process that is kind of ongoing across our whole system, but it does tend to be a little bit more clinic by clinic how people set this up. So this is sort of what we've figured out works for us. We have set up a system whereby there is a referral process. We have a referral that we've been able to create in our electronic medical record, which has been helpful. But I can tell you that old habits die hard, and this referral has not been around forever. And so many of the patients that get to us, it's word of mouth, it's personal emails from a hospice provider or a phone call from a hospice provider or some oncologist that I know in the community who just directly come to me to ask for the patient to be seen. So we try to get the patients in as quickly as possible. Time is of the essence for many of these people. So we try to get them in within a day or two, ideally, of getting the referral. So at the first visit, we do the evaluation for eligibility. We get the first verbal request. That's where they state to us that this is something that they're asking for, that they're interested in. We, at the same time, give them the written request, which is one of the 4 legal requirements that they complete this legal request, tell them, fill this out, bring it back to us at the second visit, and set up the second appointment and consultant visit at that time before they leave. If somebody is telling me, I generally also like to gauge kind of their readiness with this. It is by no means required for a patient to say, yes, I know exactly when I'm going to take this medication. But it's helpful for me to know in order to better advise them. But it's also helpful for me to know how quickly I need to line up my consultant and get everything and all my ducks in a row. If they say, as soon as I have the prescription in hand, I am going to take it, then I make sure everything is lined up perfectly, that their second visit is as close to 15 days after the first visit, which is the mandatory waiting period in California. If we didn't mention it, I'm in California, so I operate under the medical aid in dying rules for the laid out in the End of Life Option Act, which is California's version of medical aid in dying. So we line that all up so that they have met all the requirements by day 15 of their waiting period so that they can get the prescription and take it whenever they want. If that is the case, we generally try to get the consultant visit done between the 2 attending visits. Otherwise, if there's not the time pressure, they say, I'm going to take it sometime in the next couple of months or maybe not at all, then I we can kind of take our time a little bit more. I generally instruct them to let us know if it's more of the latter case, maybe in the next couple of months. Instruct them to let us know about a week or so before they plan on taking it, so that we can then write the prescription and send it over to the pharmacy and make sure that they get that with enough time to be able to fulfill their final wishes. We used to just prescribe as soon as they were done, but we learned we not super comfortable with that medication just kind of being out there in the environment if someone's not going to take it, or if they're going to take it in a few months, because it is literally poison. And so I don't like that hanging out there in people's houses if I'm not sure when they're going to take it. Okay, next slide. Okay, some pitfalls and how to avoid them, because this would not be that helpful a talk from me if I didn't use some of our wisdom in this area to show what we figured out works and doesn't work. So first of all, video visits work really well. There have been questions about the legality of video visits, but at least in our law, there is no explicit prohibition on video visits in the law. And there's implications that it should be fine. And so they work very well, because many of these patients are coming from a long distance to receive this care. I've had more than one patient drive to me from 4 hours away in order to see me to receive this care. And that's a tall order to ask when someone is dying, because the people who are trying to access this tend to be suffering, and it might be very difficult and a huge imposition and limit their access if you're saying you have to come to me and see me in person, especially when they don't have a provider anywhere in the vicinity. With the exception of shaking their hand, there's really no physical exam where I have to be physically laying hands on them during these visits. So video visits are totally appropriate. I've had people ask me, well, what about the provision where you have to make sure there's no coercion? You've met with them one-on-one. This is, they have a cell phone. I can just tell them pan the room so I can make sure that we're alone while we have this conversation if I'm truly worried. So I can make sure that there's no coercion and have that one-on-one discussion with them. So it certainly doesn't prohibit that. Provider pools. So it's very helpful to have a list of physicians or providers that you know of who are willing to provide this service, so that you can set up patients that are in their geographic region, and that if you're feeling overloaded, you can ask other people to share the load. Because sometimes when this is something that you believe in and you do and you offer, you do end up getting a number of patients being sent to you. So, being able to not overload yourself is important. Having a good relationship with a particular pharmacy or two. So the medications that we use, and I know that there's going to be a separate talk where we talk about the actual medications itself and regimens and how that works. They are compounded, and so they have to be given out by a compounding pharmacy, which automatically limits who you can go to and where you can get these things from. But they are all medications that are very readily available to compounding pharmacies. There's nothing too exotic in the regimens. And so they're things that people can, compounding pharmacies can provide if they are willing. And so we here have a pharmacy that we work with. We have a very good relationship with, and they make sure that they keep all of the requisite ingredients on hand. And if I call them and I say the patient wants this tomorrow, they will bump it to the front of their line and mix everything up and get it out to them with either a courier service or a next day FedEx to get it to them within a day or so. So having that relationship with the pharmacy, knowing the limitations of your pharmacy, how long it's going to take them to get the medication out is important. So I'm saving the best for last in terms of importance. So your care of the patient does not end when you say goodbye to them on that last visit. you are now responsible for what happens to that patient in terms of whether they ingest or not. And so generally where I leave off is where hospice picks up. Most of the time I have patients that are already in hospice, and if they're not enrolled in hospice, please get them enrolled in hospice when you start this. There are many times when people come to me for evaluation, short aside, when people come to me for evaluation and it's, they're not enrolled in hospice and they have metastatic cancer and they're having a lot of problems with their pain. And I take a look at their medication list and they're on, 4 Norco a day. And I say, well, if you're looking at this as an option, you should also be on hospice. And if pain is your main issue that's making you reach for this, they are very good at pain and pain control. And, I get them on hospice and perhaps that's all that they needed. There are many different ways to die. And, this whole thing, all of medical aid in dying is about giving people one more option so that they can decide what is right for them. And if they go off with hospice and they have great pain control and their suffering has been abated to their satisfaction, a lot of those patients I don't ever end up seeing again for their second visit because they were satisfied with hospice and they didn't need this. This is really an option for the people who have tried other avenues of suffering, alleviating suffering, and they say, this is, I can't get it. So communicating with hospice, making sure that hospice is aware of the patient's wishes. So I'm usually calling the nurse on for that patient who's in charge of their care and saying, are you aware Mr. So-and-so is seeking medical aid in dying? And he's saying that he wants to ingest next week. Then when that comes up, okay, he's planning on ingesting on Wednesday. Make sure that you have a team of people on board assigned to him for Wednesday who are comfortable with this. Ideally, someone who's done it before, because I am a primary care doctor with a busy primary care schedule. And unfortunately, I personally am not able to make it to the bedside for the vast majority of my patients who are ingesting. So hospice is they are my boots on the ground. I generally make sure that the nurse who is going to be physically present for the ingestion has my personal cell phone number, and I tell them, text me when they take their first bottle, text me when they fall asleep, text me with questions, call me with questions or concerns, so that I'm right there with them. The nurses appreciate that. Hospice appreciates that. They don't feel like we're dumping on them. The patients appreciate knowing that the nurse is directly communicating with the physician and that everybody's on board. It makes me sleep better at night so that I know exactly what's going on. I can't understate the importance of having that direct communication with hospice and knowing when the patient's ingesting, so that you can troubleshoot. Okay, next slide. All right. I get this question a lot. I do a lot of training with physicians, and I do a lot of outreach to physicians. When a patient is requesting, I always throw it back to the primary doctor to see, hey, we are okay taking this patient on and doing all of this process ourselves, but I've seen that this patient has been seeing you for the past 25 years. Do you want to be involved at all in this process? Do you want to either be the consultant or the quote unquote attending and the prescriber? And if you haven't done this before, don't worry, I can talk you through it and train you on how to do it. And so in that context, I get a lot of questions about like, ooh, I'm not comfortable, or I have questions, or is this against our oath as physicians? So there are 4 bedrock pillars of bioethics when it comes to medicine. There's beneficence, which is that we are responsible for doing what's in the patient's best interest. There's non-malfeasance, which is commonly thought of as the do no harm, primum non nocere part of medical bioethics. There's justice, meaning that we are equally applying our medical access and care to all patients, and autonomy. So respecting somebody's wishes, that they are the expert in their own bodies and their own care. So apparent questions in medical bioethics happen when there is a potential conflict between some of these bedrock foundations of these pillars of medical bioethics. So the question comes up, is this violating non-malfeasance? Is this harm? And I think it really gets at the question of what is harm, and is forcing someone to live through their terminal suffering. This isn't a question about patients whether or not they're going to die. These are people who are going to die, and they're going to die in short order. And so the question more is allowing them to determine how they live those last bits of their lives. You're not choosing whether or not they die. You're choosing whether or not to allow them allowing them to write that last sentence of their lives, that they have that power. And I see this again and again when I talk with patients and I ask them why they're doing this, or talk with the families about their experiences with the ingestion and how things went after the patient has passed. And again, I hear these amazing stories of, dad was so fearful about this, or he was starting to suffer irrevocably. He was bedbound. He was really starting to suffer loss of dignity that he was very explicit he didn't want to experience at the end of his life. And we did this, and having this available made him so relieved. It made him so happy to know that he didn't have to then waste away for an additional month or two where he wasn't able to take care of himself. And so, and the patients' families are incredibly happy that their parents got to choose this option, that they also didn't have to experience their patients suffering secondhand and see their mom or dad suffering the way that they knew they didn't want to go through. And so that this aid in dying gift seems to just expand well beyond the confines of the patient in front of you. It's really the families are additionally incredibly supportive in the vast majority of cases, and just grateful that this option existed for their mom and dad. And so because of that, I very quickly came to see medical aid in dying for what it is, which is a super powerful tool for patient empowerment and restorative justice. So this is about people who are at the end of their lives and feel totally helpless and powerless to change the course of the inevitable, that they are wasting away and they feel themselves wasting away and they are powerless to stop it or do anything about it. And this is their life, and this is kind of an important epoch in their life, and they just are unable to do anything about it. And so this is, for many people, super powerful way of giving them some of that power back. I put up there, is it suicide? And I like to read this quote. There is a work group for the American Psychological Association that put out a report. It's kind of a position statement in the year 2000, and then was adopted into their neutrality position statement in 2008. And it says, it is important to remember that the reasoning on which a terminally ill person whose judgments are not impaired by mental disorders bases a decision to end his or her life is fundamentally different from the reasoning a clinically depressed person uses to justify suicide. This is not suicide. This is not a question of this person living or dying. This is a question of that person being allowed to take charge of their own lives at the end of their lives. Okay, I'll move on to the next slide. So Sam was alluding to this earlier. It is important also to note that for all of the patients who have had similar reports of where they say, we got to have a memorial for dad while he was still alive and he went out with the sunset, surrounded by friends and family, which is a remarkably common theme of a story that I hear from families, which just sounds so amazing to be able to do that. I have just as many stories, unfortunately, of patients who come to me desperate, to see me for that first time, and you just know evaluating them that first time, this is not someone who's going to make it through the waiting period. This person is going to die in the next 15 days. And I try to be as upfront as I can with that patient or those family members to kind of warn them that they might not make it. And I'm talking with hospice during that time to make sure that, you know, whatever they can do for that person's suffering, they're able to do that. But a lot of people end up dying during the waiting period. And the question is why? We do know that some of it has to do with people come to acceptance late. Some people do. You know, and you can see that in a subset of patient data that I looked at for our patients, about 20% of them passed away before their first appointment with us, but about a third of them died during that waiting period. And it's pretty heartbreaking to see people go through that and see patients go through that and know that you are powerless to help them. This is, so 52 of the people in the 66 patient subset have died. And so this is the kind of breakdown of that, where you see slightly over 50% of them dying before having satisfied all the requirements. So it's a pretty sizable number and speaks to institutional revisions and how we can better make access for patients, but also this kind of potential room for improvement on the legal side of things, that so many people die during the waiting period. It's important to note that this is not a decision that people have come to lightly. And it's not like they woke up that morning of their first visit and said, aha, this is something I think I want to do, which the waiting period seems to imply that's what people do, that they need a 15-day cooling off period of time to make sure this is really what they want. These people frequently started thinking about this a month or two before, and in some cases started looking for a provider a month or two before. So this is not a capricious decision, and the waiting period is just extra. Okay, I'll go to the next slide. I know that I'm running over. So it's also important to say that many of the physicians, if anybody here was at the conference, the National Clinicians Conference on Medical Aid in Dying last year in February, immediately before the viral apocalypse hit us, you probably noticed that the average age in the room was probably around 65 or 70. And there's nothing wrong with that. But this is, in order for medical aid in dying to propagate and to become normalized in an effort to improve patient access, because if you've gotten anything out of these slides, it's that access is a big bottleneck for a lot of people. We have to be keeping our eye on the ball, which is training the next generation of physicians to accept and be willing and open and be trained in order to provide this service. So I am faculty at the Sutter Family Medicine Residency Program in Sacramento, California. And we've been training our residents in this for the past several years. And we've graduated a number of them who are now practicing aid in dying in their communities as attending physicians. And in order to keep this going and in order to improve access for patients, we really got to get the word out and start training at other family medicine residencies and internal medicine residencies, especially around the country. So while everyone that's doing this is fantastic, it's these young whippersnappers here. This is a picture from one of our resident retreats, obviously pre-pandemic, over in Santa Rosa a few years ago. I don't see myself in this picture, but I'm in there somewhere. And with that, we'll move on.
Thank you so much, Dr. Spielvogel. Great presentation. And I know we have a ton of questions, so I'm going to try to answer some of them and go quickly through the rest of the presentation, and then we'll answer questions live. So here at Compassion and Choices, like I said, we have a lot of experience since the first law passed in Oregon, and we've learned that you can't just pass an aid in dying law. You have to stick around and work on implementation. And if you're a volunteer with us, please, please, please plan on sticking around and volunteering after the law passes. And I'm going to share with you some really important things we have learned to make sure that patients can access the law after the law has passed. So structural, working with health departments has been so incredibly helpful. This is a picture of an annual conference that we do with DC Health in Washington, DC, where trained physicians teach other physicians through clinical medicine how the Washington, DC law works. I have worked very closely with the Hawaii Department of Health. They did a phenomenal job. They had about 9 months before the law went into effect, in which they did a lot of clinical education. They worked with hospitals and healthcare systems to get everybody ready. The next slide is very important. The policies and procedure that your healthcare system or hospice implements is so important. At healthcare systems, what we look for is an internal referral policy. This is so important because if a patient goes to your healthcare system, and let's say they absolutely let doctors support patients in the option. However, if they go to a doctor who personally doesn't want to support them in it, and they don't refer the patient to another doctor who will support them, then oftentimes this patient falls through the cracks. And, it's hard to find a doctor when you're healthy. It's 10 times more difficult when you're terminally ill and dying and trying to access this end of life option. Hospice is also so important. Somebody asked about who's enrolled in hospice. We hope everybody's enrolled in hospice. The questions, you should interview your hospice if you're a patient. What we hope for hospices is that they let their doctors act as both the attending and consulting providers. And we also hope that they let their staff be present when the patient takes their medication. Unfortunately, there's some hospices that don't let their staff be present, and there's no reason for this. It's authorized, in over 50 years of combined data we have from all the states, there's never once been an incidence of coercion or abuse. The law is in place and it's fine. You can be present when the patient takes the medication. Next, medical mentoring and training. This is our national medical director, Dr. David Grube. In the old days, he used to travel around the country, and he does a lot of clinical webinars that are specific to your state, especially once the state first authorizes. So he can train doctors and nurses, social workers. It's so important that all of these medical providers understand the steps for your unique state so that they can support patients in the option of medical aid in dying. We have a great source called Doc to Doc. It's a free confidential consultation service. You can call the number on the slide or go to our website, and you will be put in touch with a doctor who is experienced with supporting patients in the option of medical aid in dying, and they can mentor you and help you help your patient. The next slide, I love this picture. This is Jake Blechta. He's a pharmacist in Hawaii who's filled over 50 prescriptions. In fact, right after this webinar, I'm doing a clinical webinar with Jake and other medical providers who now have 2 years under their belt of supporting patients in the option of medical aid in dying. And they're doing this clinical webinar for other medical providers, including pharmacists. So Jake is actually a volunteer with us. He does clinical teachings for nurses and social workers. He teaches them about the medication, how to mix it, and how to support the patient with that medication. So we also have, just like our doc to doc, pharmacist to pharmacist consultation. You can call, it's the same number. You just make sure you push the right button when you get there. Public presentations and outreach. So many people don't understand what this law is. They don't understand how to access it. So we like to go around to Rotary clubs, Kiwanis clubs. Now it's even easier because we just Zoom from home. So if you're interested in volunteering, we love our medical provider volunteers as well as our non-medical provider volunteers. You can see Sam DeWitt there. He is one of our regional managers, and Bob Drake, he's our national medical outreach person. They also work on calling hospices, healthcare systems to try to find out, what is your policy? What are your procedures? We have free templates of policies and procedures that we can share out with healthcare systems and hospices and hospitals to make sure that they have really good internal procedures so that they are supporting patients and patient-directed care. When we have the funding, we try to produce public service announcements. We rely, Compassionate Choices relies on donations. Our next slide, public media. We love working with people who have firsthand experiences with medical aid in dying, who feel compelled to share their personal stories. This helps get earned media so that people understand what this is all about. This was a great article by a fabulous physician in New Jersey, where they also have authorized medical aid in dying, Dr. Jessica Israel. Next slide, protecting the law. We have a legal team that works hard to make sure that the law stays put and that people are able to access it. And finally, amending the law. This is where we're at right now in a lot of authorized states. This is Malachi. He's a volunteer with us in Hawaii, where we're trying to amend the law. A lot of the states are trying to do what Oregon did, which is allow that mandatory minimum waiting period to be waived if the patient's unlikely to survive it, since so many patients don't. Some states like Hawaii and Washington are also trying to authorize nurse practitioners, advanced practice registered nurses, to be able to support patients in the law. So I tried to answer some of your questions in the final slides, and now we can go to Q&A.
Wonderful. Thank you, Samantha. Thank you, Dr. Spielvogel. We have 4 minutes for questions. So we are going to do rapid fire lightning round. Okay. So the first question is for Dr. Spielvogel. And that question is around administration with a feeding tube. Can a patient administer medication through a feeding tube for medical aid in dying?
Yes, they can. So the law, all the laws are pretty consistent that a patient needs to ingest the medication through a willful act. It doesn't say what route by which they ingest it, but ingestion implies using the GI tract in some way. So it can actually be administered rectally as well for patients who are unable to use their mouths and don't have a feeding tube. But if they have a PEG tube or something like that, they are able to essentially push the meds through. It is a liquid, so it will pass fine through a feeding tube.
Great. For Samantha, there were a lot of questions around this idea of religiously affiliated healthcare and where their prohibitions might lie. So is that prohibition generally just for attending physicians? Does it apply to consulting physicians? What about nurses, social workers, chaplains? And then a quick little follow-up on it. For a person who is receiving care there, what are the types of steps that they should take for getting a referral outside or reestablishing care?
That's a great question. And it really depends on the facility you're at. And remember the policies and procedures I talked about. That's so important because there are some places that say you can't even talk to your patients about medical aid in dying. And there are non-religious healthcare systems that have these kind of policies in place sometimes, unfortunately. And so I think somebody asked about employment. If you're employed at a religious healthcare facility, but you can also work independently, then depending on, your state, there could be a possibility for you to support patients. But if you're a patient that's at a healthcare system where your doctor's not allowed to practice, I would encourage you to ask your doctor to refer you to a doctor who can support you. Depending on the state you're in, there's a lot of other resources for you.
Wonderful. Thank you. A question for you, Dr. Spielvogel. For a person whose individual physician is unwilling to participate, but they're in some type of larger healthcare system, where are kind of the levers that they can look for getting a referral? For example, if they were at Sutter Health, how would that work for them?
Yeah, it's a good question. So we do have a public web page that basically says, if you have any questions or want a provider, there's an email where you can email, and it goes to our same coordinator who coordinates all of our referrals. So I would encourage people to ask their physician, their personal physician, and if they don't, press them for, is there someone that you can refer me to? And if they say, which is legal under the law, I don't want to have any part of this, and I don't want to refer you to anybody or give you any additional information, then they can start asking, I would say, if there are any hospices that are attached to their institution. So we have a hospice that's attached to our institution, and they know all of the ins and outs of that. Other physicians, looking up palliative care physicians at their institution to see if they know anybody. Not all the palliative care physicians do this, but they generally do know who does. So basically asking around, which isn't the best for patient access and patient care in general, but that is sometimes what people run into.
Wonderful. Thank you, Dr. Spielvogel. And thank you to Samantha and Dr. Spielvogel for all of the insight that you brought. We are unfortunately at the end of our time for questions and answers, but the good news is I'm going to turn it over to Crystal to share some resources that are available where I think many of the questions that I've seen come up in the chat box can be answered. So on behalf of Compassion and Choices, I want to thank everybody for being a part of this webinar and turn it over to Crystal at City of Hope.
Thank you. Some of our resources here. Compassion and Choices has a plethora of free resources you can find on their website, including a free confidential consultation for doctors with other doctors who have practiced the full range of end-of-life options and can help mentor other doctors. We're happy to announce another educational opportunity, which is now available through Medscape on medical aid in dying, my clinical guide and practice points. For more educational opportunities or to reference today's recording, please visit us at cityofhope.org/CME. Please join us next month on March 4th when we will discuss cinema at the end of life. And thank you for participating today. We hope you'll join us next time.